anesthesia risk doesn't start with the medication. It starts with the patient. And if you're overweight, even mildly, your physiology changes in ways that make anesthesia riskier. So you'd be shocked how often I hear this. It's just twilight sleep. It's just wisdom teeth. It's not general anesthesia. I'll be fine. But here's the truth. Anesthesia risk doesn't start with the medication. It starts with the patient. And if you're overweight, even mildly, your physiology changes in ways that make anesthesia riskier. And you don't need to be in an operating room under general anesthesia to be at risk. You just need to be sedated in a chair with metabolic dysfunction in the background. So let me walk you through exactly why that's the case and what the data shows. So welcome everyone. This is episode 67 of the Obesity Project. My name is Dr. Mark Shankman. I am an oral and maxillofacial surgeon. Wisdom teeth is my primary thing that I do, along with extractions, regular extractions, putting people to sleep, of course, doing biopsies, doing implants, bone grafts, prosthetic surgery. So all of these things are within my realm. And today I'm really here to talk to you about what happens in obesity, and particularly when it comes to anesthesia for dental procedures. Now, the one thing that I want you to understand about dental procedures that is different than in the operating room is that in the office setting, we don't actually put in a breathing tube, and we don't have a machine, a ventilator breathing for you, and you're not breathing inhaled gases, which keep you at a much deeper level of anesthesia. So you are asleep, but it's sort of this deep sedation area where we have to give you enough medicine that you fall asleep, but not so much medicine that you stop breathing, and you need to be able to breathe on your own. So let's talk about first how obesity narrows the functional airway. So in dentistry and oral surgery, 90% of sedations happen with the patient in a supine position, meaning they're lying back flat, their head is tipped back, and their mouth is open. But in obese patients, that positioning can collapse the airway. Why is that? Well, because excess fat around the neck, tongue base, chest wall reduces airway diameter and compliance. So even mild sedation, like doing Versed or midazolam, which is a water-soluble Valium type drug, relaxes the pharyngeal tone even further. So there was a study from the Journal of Anesthesiology that found that obese patients are up to 3 times more likely to experience upper airway obstruction or airway blockage under sedation compared to normal weight patients, even when breathing spontaneously. And this was done by Juven et al. In 2003. So I like to give real world examples, and all of the real world examples that I'm giving, the patient's names are protected, and you don't have to worry, no HIPAA compliant issues here. So I once had a patient come in for third molar surgery. They had an ASA class 2. ASA is American Society of Anesthesiology. Class 2 means they have some very, very mild systemic disease, but nothing, sort of life-threatening, nothing major, metabolic dysfunction. And they had a BMI around 36, so they were classified as obese. As soon as the midazolam hit, their tongue felt backwards, and snoring turned to stridor. And stridor is where people are struggling to breathe, and they're making sort of crow-like noise, like, "Ugh." So that kind of noise. We had to position them upright, apply a jaw thrust, and suction continuously just to maintain an open airway. And this was conscious sedation, not even a full general anesthesia. So no, it's not just sedation, it's sedation on an altered airway architecture. So people have, their airway is definitely more limited because of all the fat and the obesity. So these patients also have a reduced pulmonary reserve, which means that we have less time to react, because the oxygen in their blood drops much, much faster. So we're going to talk about exactly what this means. So in healthy patients, there's a buffer zone. And if breathing slows or even stops, oxygen saturation, which is the amount of oxygen dissolved in the blood, takes a pretty good little while for it to drop. However, in obese patients, that buffer shrinks fast. This is because functional residual capacity, or FRC, the volume of air left in the lungs after passive exhalation. So you take a deep breath in, you kind of relax the air out, and what's left behind in the lungs is the functional residual capacity. And that FRC is reduced due to excess abdominal and thoracic weight compressing down the diaphragms and the lungs. So there was some research in obesity surgery by Pelosi et al. In 1998 that showed that in obese individuals, FRC can be reduced up to 50%, making them much more prone to a rapid desaturation or a lowering of the amount of oxygen in the blood. Now, if your oxygen level, which normally is around 97 to 98%, meaning 97 to 98% of your red blood cells are carrying oxygen, if your oxygen saturation drops to less than 90%, that means that I actually have to go in and I have to breathe for the patient. And so that oxygen saturation and that capacity is really important. So the research by Pelosi showed that in obese individuals that FRC could be reduced up to 50%. And that can cause them to desaturate or lose the amount of oxygen dissolved in their blood very, very quickly. So what's the translation? This means that if your oxygen drops, you have about half the time to fix it before critical hypoxia or lack of oxygen sets in. So let's use an example. In a healthy adult, the oxygen saturation, or SpO2 as it's called, may take about 2 to 3 minutes to drop from 100% on oxygen. So that 97 to 98% I said is pretty much on room air. We oxygenate and pre-oxygenate the patient, so they're usually at about 100% before we start doing anything. And so in the healthy patient, that desaturation, that drop from 100 to 90%, happens in about 2 to 3 minutes with their slowed or stopped breathing. However, in an obese adult, that drop can happen in under 60 seconds, especially in the supine position. So in sedation dentistry, where we rely upon nasal cannula flow, the little prongs in your nose that deliver oxygen, or minimal supplemental oxygen, that matters. So the other thing obese patients have is altered drug distribution and clearance. So let's talk pharmacokinetics. Pharmacokinetics basically means where the drugs are functioning and where they're being distributed to. So most sedative agents like midazolam, fentanyl, propofol, they're lipophilic. They like fat, and that means they get stored in fatty tissues. So in obese patients, this increases the volume of distribution. So drugs may take longer to reach their effect. They linger longer and they accumulate unpredictably. This makes anesthesia in an obese patient very, very dangerous. In a 2011 review in Anesthesia and Analgesia by Ingrande et al., in 2011, they found that lipophilic drugs like propofol and fentanyl, drugs that go to the fatty tissues and are redistributed there, required careful dose adjustment in obese patients due to the risk of overdose and delayed emergence. So why is this? Well, the reason is that those drugs go to the fatty tissues and they stay there, not doing their effect, but they kind of hang out there. And then they're re-released back into the bloodstream. And guess what that does? Gives you the ability to overdose someone by giving a normal amount, but now you have this released from the fatty tissues drug that now overdoses the patient. Also, you can get delayed emergence because even though you stopped giving medicine and they should start waking up, this drug that's coming out of the fatty stores keeps them asleep. So big problems when it comes to obesity and anesthesia. So let's use an example. Let's say I go ahead and titrate about 2 milligrams of midazolam, expecting about a 30-minute window of working time. In an obese patient with hepatic all right, with fatty liver, clearance slows, and sedation may last twice as long. And add insulin resistance, non-alcoholic fatty liver disease, or NAFLD, or kidney strain. Now you've got impaired metabolism and excretion and unpredictable drug hangover. All right, the fourth thing that happens in obesity and outpatient anesthesia is we see insulin resistance and the amplified stress response. So, metabolic dysfunction isn't just about blood sugar, it's about how your body responds to stress. Anesthesia, even conscious sedation or a light sedation or a twilight sleep, is a controlled physiologic stressor. And your body needs to regulate things like blood glucose and cortisol, catecholamines, which is like epinephrine, norepinephrine, heart rate and pressure, respiratory drive. All of these things need to be controlled and regulated. Well, in a 2015 paper from the Journal of Clinical Endocrinology and Metabolism, researchers showed that insulin resistant individuals have a blunted counter-regulatory response to stress, meaning that they may not handle sedation as predictably. And so let's talk about the real world consequence of this blunted, response. So a metabolically unhealthy patient might look stable until they're not. They're more prone to blood pressure drops, desaturation, paradoxical agitation. So, meaning they get disoriented, they get almost combative, and it becomes very, very difficult to manage that patient and get the surgery done in a safe manner. Also, can create slow recovery. So, this is why we don't just look at BMI. We need to look at metabolic health because it affects everything downstream. So, I hope that you understand now how obesity affects outpatient anesthesia. It can be very, very dangerous. We have to be super careful. You're actually safer sometimes having a breathing tube in and being in an OR setting. However, really difficult to find an OR setting to get your wisdom teeth out. So this has been episode 67 of the Obesity Project, why obesity makes anesthesia more dangerous, even outside of the OR. So let me say this clearly. You don't need to be having major surgery to be at risk. You just need to be sedated with an airway that's harder to manage, oxygen reserves that deplete faster, and a metabolism that doesn't follow the rules. And for healthcare providers, that means we have to anticipate complications, not just react to them. And for patients, that means understanding that your weight and metabolic health affect your safety in every setting, not just the OR. So fix the signal, improve the margin, and make anesthesia and recovery safer. Thank you so much for watching. I hope you learned a little something. I know most people that are obese or insulin resistant and metabolically dysfunctional have no idea about the effects of outpatient anesthesia in an office setting. Now you know. Be prepared. Let's try to fix things, and let's discuss this further with your treating physician or surgeon. So thank you so much for watching. Like, share, and comment. Subscribe. Hit that bell notification. We're going to stay on this dental topic for a few more episodes. So stay tuned because in episode 68, we're going to explore why the carnivore diet or a ketogenic diet doesn't just fix insulin. It actually protects your teeth. I'll see you in the next one.